Hello, dear dental friends from all over the globe. I trust that you are all safe and healthy in this special situation. We should all have been seeing each other around in symposiums all over the world, but at this given time, we will be meeting up on online platforms like this. So it's a pleasure to welcome you to the next session of this Straumann Immediacy Essentials Symposium. You just heard our dear colleague, Dr. Colucci, talking about the digital way in immediacy. My topic today will be to talk about the posterior restorations. And the posterior immediacy, is it straightforward or does it have any pitfalls? During the next hour, I will try to highlight some of the pitfalls that might be, and I will also try to show the clinical protocols of how to do this and the case selection. And the case selection is probably what you will need the most. So, just a brief summary of my own dental history. I've been in this game now for about 20 years. About 5 years ago, we founded Oris Dental in Norway, which is a DSO that runs now about 25 clinics in Norway. We focus on education and pushing everybody up the educational ladder. So the Oris Academy is where we run our courses and lectures, and we travel all over the globe to do so. I've been lecturing for different implant companies through the years, and recently, since 2017, I've been involved with Straumann. So probably why I'm invited here today. I did a webinar some months ago about the aesthetic zone and decision making around immediacy. I call today's lecture the part 2 because we will look upon many of the same topics, but for sure we will now focus on the posterior area, and we will focus on single restorations, which is kind of the bread and butter of every dentist today. So doing the right decisions, the case selections, the overall treatment plan, the holistic view of the patient is what we need to do even in the posterior zone. After I'm done, there's going to be a Q&A session, so please, if you have any questions, feel free to post them and we will try to get through all of them, or we do what we can do in the time given. During this lecture, I will try to be clinical, practical, and transparent, because not everything we do is a success. We do have failures. Shit happens. And we need to talk about that too, because it's from errors we learn the most. So I'll try to show you a way of educating yourself in this specific topic around posterior immediacy. So no matter what we talk about in implant dentistry, we need to keep in mind that there is a primary goal within implant therapy in itself. And the primary goal of implant therapy will be successful treatment outcome, high predictability, good long-term stability, and low complication rate. Given that primary goal should always be in your mind when you plan to do a treatment and when you perform a treatment to your patients. Nevertheless, we cannot always stay in the safe zone of what we always did. We need to develop and we need to get more on the patient side of this treatment, because basically it's the patient that is his or her own general manager of his or her own teeth. So being focused on patients with the secondary goals of implant therapy being the fewest possible numbers of surgical interventions, low pain and morbidity, short healing periods, and short overall treatment time. Then we have the acceptance from the patient itself to do this treatment. So we're not revolutionizing implant treatment. We're not developing any specific very new thing. It's been on the market for many decades. But what we try to do is we try to refine all the things that we are doing to our patients, being the procedure itself, being the equipment, being the design of the implant system, being the development of prosthetic components, and also being the development of concepts that will have the patient in mind when we talk about time to tooth. So, posterior restoration, which is the topic today. Is it any use to talk about it? What is the need for posterior restorations? Well, you do your crowns and you do your composites and everything, you do your root canals on teeth. But let's look at a large German population study from back in 2006. What you will see is that the tooth loss in the population between 65 and 74-year-old Germans, where if we talk about the first molar, you'll see that tooth number 1-6, tooth number 2-6, 3-6, and 4-6, they're on average missing in about 70% of the population. So yes, there's a need for posterior restorations. What is the long-term prognosis for these replacements? Do we know that we can promise any long-term stability and survival rate and success rate on these types of restoration if we compare them to our traditional work? Well, let's look at one of the reports that the Icelandic Dr. Pettersson published 8 years ago, where we looked upon survival rate on different kinds of prosthetic restorations. And it was done on a 10-year basis. Well, what they found was that single implant crowns had a survival rate of about 90% on a 10-year basis. And that was comparable with a tooth-supported bridge. And if we compare the non-invasiveness of doing a single crown on an implant compared to a 3-unit fixed partial denture or bridge, we know that we would choose an implant basically any given Sunday nowadays. So about 90%. So there's a good long-term success and survival rate on implant restorations, single teeth. So what about the patient perspective? What are the patients concerned about when performing an implant treatment? What would any patient in your practice ask you when they come in and you suggest to do an implant treatment? Well, most of them would ask, how long time does it take before I get the tooth? Because they would like it to be as short as possible. How many times do I have to visit your office? Nevertheless, it has been a very hot topic with immediacy before. But after this specific situation that we're facing globally now, that we need to reduce the time spent in our office, the visits to our office due to the COVID-19 situation, immediacy is basically a very good solution on reducing the numbers of visits to your office from each patient. And also, the patients are concerned about aesthetic and the functional result. But very many of them would be dealing with as successful as possible, because we cannot create miracles every day. We need to do our best to get a functional and aesthetic result. And there is nothing in the literature today that tells us that we could not obtain a good result, a successful result, by using immediate procedures. When we deal with the posterior sites, we deal with different challenges than what we have in the anterior sites. What do you face to be the challenges in the posterior sites? Well, to me, I see access as one of them. So mouth opening capability of the patient is definitely one of them, no matter what procedure you're doing. The primary stability of an implant in the posterior sites could be challenging due to the fact that we have a different bone quality in many of these sites. The closure of the soft tissue, if you do an extraction of a large molar, it's difficult to close the soft tissue without raising a flap. And as a principle, I try not to raise flaps. Sorry for that one. The gap between the implant and the bony walls of the extraction socket needs to be dealt with. We need to do a choice of whether we fill the gap or we leave it open. The emergence profile could be challenging in posterior sites due to the fact that we have a broad tooth coming out. If we have a narrow implant, it might be challenging with a functional and well-designed emergence profile. And also the retrievability, the type of restoration we choose. Do we choose a cemented solution? Do we use a screw retained? Importantly enough for us is that we should be able to remove the restoration if needed and replace it easily for the patient. So let's look at this case. We have a failing upper right molar. Tooth number 16 is failing. There's caries under an old crown, it's root canal, and the restorative prognosis is nothing. So it's decided to replace that tooth with an implant. So what are the treatment approaches we can choose from, and which aspects will be important to consider when we do a treatment approach choice? Well, you'll have several aspects to consider. First of all, you have the patient. And the patient is definitely one of the major players in deciding a treatment approach. The second major player is definitely you as the clinician. The third major player is the biomaterials and the tools that we're using. And in this case, we're using implants. We're using titanium screws. So what could be different with them? Well, as you know, it's the surface characteristics, is the implant design, it's the prosthetic connection, and also we have the extra biomaterials, the bone substitute we might be able to use. We need to consider all of these, because all of them will be a part that influences the treatment approach. If we look upon the patient, there's several risk factors. We have the medical risk factors, we have the dental risk factors, we have the anatomic risk factors, and also the habitual, like smoking. So they all need to be considered as a part of the treatment plan. On the clinician side, it's the balance between clinical skills and knowledge. It doesn't matter how much you know if you can't perform it in the clinic. And it doesn't matter how brilliant surgeon you are if you're not able to translate knowledge into clinical reality. So all of these aspects need to be considered by your patient perspective and also by the clinician perspective. On the biomaterial side, it's the characteristics and it's the documentation. And all of these things will lead to, eventually, a treatment approach. And that treatment approach needs to be based on documentation, on risk assessment, and on the complexity assessment. So, I mean, do you have the skills to perform this treatment or not? We need to be honest with ourselves. We don't know if the complexity is too much to perform the treatment ourselves and that we should refer it. It's better to build up your self-confidence by allowing yourself to start with straightforward cases and then advance to the advanced cases, and then maybe after a time advance to the complex cases. But it's important to be honest with ourselves about this. So, summarizing the treatment approach, it gives you a lot of choices. You have to evaluate all the major players in this game to do the right choice. And when it comes to biomaterials, like the implant, my honest belief is that we should choose an implant system by respecting the patient, the substrate that we are actually treating, the indication and the location that we are putting an implant in, which also affects the bone, at least in the quality way, and also the quantity of the bone is important in this one. The biological principles needs to be respected when we do these treatments, and the documentation of each implant system, the surface, the prosthetic connection, the strength of the implant needs to be considered when we do these treatment approach choices. So if we look upon that case, what can we choose? What kind of immediacy can we choose? Well, we could choose immediate implant placement. That is when we place an implant immediately into an extraction socket. That is what we call a type 1 placement. The type 2 and the type 3 placement is early placement. Type 2 will consider the soft tissue to be closed. Type 3 will consider this, beginning bone healing in the area. And also the type 4 placement, which is a delayed or typically what we call a conventional placement of the implant, is done 6 months after, like we did it before, years ago. The immediate restorations, or what we call provisionalization or temporization, is an immediate restoration placed upon a freshly inserted implant that is placed there at the time of surgery. And the characteristic of this type of restoration that there's no occlusal contacts. It's not loaded. There's no functional contact on the restoration. So if the patient is compliant enough to understand that this is not a chewing tooth, there will be no forces applied to that specific implant. It's what we call a smiling tooth. On the other hand, you might have what we call immediate loading. And immediate loading means that we have functional occlusion on the temporary or final prosthesis that is inserted into the patient within a different, there's different definitions of what is immediate loading. We go back in time, it's within 24 hours. The recent consensus that came out of ITI in 2018 said that it was within a week. And that's more of technical reasons, because it's not always easy to fabricate a temporary or permanent restoration chairside, or even on a short notice with a dental technician. So within a week is now accepted as one of the immediate loading time frames that goes within the definition. What we do is that we try to place the temporary prosthesis within 24 hours when we call it immediate loading. And immediate loading we traditionally only perform for full arches. Single teeth restorations are always kept immediate restoration without occlusal contacts. So, summarizing the choices, and what we do is that we're trying to be patient-oriented. That means that we try to focus on shorter treatment. We try to focus on shorter time to tooth, and definitely fewer surgical interventions, depending on one thing. We need the benefits to be bigger or exceed the risks. So we can't do immediate all of these different treatments on all cases. We need to be very specific on our case selections. And that's what I hope you get from this lecture today, is some hints and some knowledge on how to do your case selections. So let's look a little bit on the scientific documentation that we have on the specific implantation and loading protocols. So on loading protocols, we do have immediate loading, we have early loading, and then we have conventional loading. On placement of the implants, we have immediate placement, we have early placement, and we have late placement. From the lecture that you saw just before me, from Dr. Colucci, which headed this group at the ITI consensus, they looked upon these combinations with all the given literature that was available in that time. This one was published in 2018, and we looked upon conventional loading was accepted as scientifically and clinically validated on immediate placement, on early placement, and on late placement. It's not a big surprise that this happens, but it's good to see that this is documented. And then they looked upon late placements, and late placements show that immediate restoration or immediate loading or late placement is clinically documented. With early loading on these types of implant placement, it's also scientifically and clinically validated. Look on immediate placement, which is my favorite. It's clinically documented that we now can do an immediate restoration or immediate loading on these types of implants. and also early loading is clinically documented. So what is not clinically or scientifically validated or documented? Well, it is the early placements with immediate restoration or loading or early loading. So the types of protocols that I'm talking about today is clinically documented and accepted as a treatment approach that is in your toolbox. So I put up some specific requirements or needs that I have if we're going to perform these refined solutions to our patients, like immediate implantation or immediate restoration. There's some specifics that you need to choose from when you choose your implant system. To me, on immediate implantation, I need an implant design that gives me the option of having an adaptive gel protocol. To me, this is fully tapered implants, so that I'm able to make a smaller osteotomy in soft bone, or that I'm able to work in extraction sockets without doing the complete part of the drill protocol. That's important issues for me. On instruments, on the surgical instruments, they need to allow me to do advanced procedures. That means that I need all these specific small details when I'm doing the surgical procedure. And it seems like a natural thing, but if you've tried different implant systems, you know that there's different on the instruments and the different on the design and the functionality of these systems. I need to have a direct connection to the implant. I need a pickup system of the implant. There can't be any carrier in between now, because we're working on and off with the implant to adjust them and everything. So it needs to be direct, and it needs to be strong, because I will be using actively insertion techniques to do this. So I will be applying forces to these implants. So strongest material there is, good for me. And also I need to rely upon, as I try to place implants as often as I can in extraction socket, and I also try to do temporization on most of these implants if it's possible, I need to rely upon the secondary integration happening as fast as possible. So I need a hydrophilic surface on these implants that allows me to trust that the secondary integration would weigh up the reduction of the primary stability of the implant as time goes by. If we look upon immediate restoration, it's a different game, because it's different things that we need. But we need components. We need components to do all the different solutions that we can do chairside. And that goes on diameter, height, all the material choices that we have in, for example, temporary abutments. Really important when you do these treatments. It's also instruments that you need to do this chairside, because if everything is about a big machinery that needs to happen due to this one specific situation, that your patient just runs into your office one day and then you need to do all this, you're never going to have this as a productive part of your business. And also this is about digital workflow. We need to be able to plan this one digital, we need to be able to execute some of this digital, and we need to be able to do the prosthetic restoration as a part of a digital workflow. Biomaterials, looking away then from implant as itself as a biomaterial, we also need these biomaterials to predictably achieve the aesthetic result we need, because we know that these biological results of extracting a tooth, they happen. So reduction of the buccal bone happens. We need to have something that actually limits the aesthetic consequences of these natural actions. And to me, the most important thing when you do your immediate restorations is having time to do these restorations. Because placing an implant, honestly speaking, it doesn't take too much time. You know what you're doing, you can do this correctly in a fairly short time. Doing a temporary restoration, it takes time. It's much more challenging, because you need to spend time on all the other specific small details in the end. So time is a very important issue when you're planning for your immediate restorations. So let's look at immediate implantation. Immediate implantation, I'm showing you a checklist that I use whenever I consider to do an immediate implant. It's infection control, it's defects, It's bone surrounding the alveolus, and combining that is also the relationship to anatomical structures. So let's look at some of these. Let's put this case in. It's a upper left premolar. You can see that the root canal is done, but there is also gutta perca inserted into a chronic fistula of that tooth. So it's not an active infection, because that's how we decide. I mean, chronic infections, it's documented even by the review by Kirkanovich in 2015. It's documented that chronic apical infections has nothing to do with the success rate of these implants placed in these extraction sockets, as long as you clean these extraction sockets carefully, both mechanically and also chemically. So this is a chronic infection. So I might say that, hey, we can place an implant in this. But we need to consider the other things. Is there a defect? Well, we know as there is a fistula, there's going to be a buccal defect in the buccal wall. It might be big, it might be small. We can consider that being inspected clinically, or we can do a cone beam CT and check it out in advance. Also, we consider the bone surrounding the alveolus. Is there any bone, mesial, distal, buccal, palatal, that we can use? Like in the aesthetic zone, we talk about the anterior zone, we always look for the palatal bone. Is there any apical bone? This case is challenging because it's in a situation where we are dependent on apical bone. That brings us over to another case like this one. So this is a deciduous tooth. And we talk about bone surrounding the alveolus. So if you look at this case, you'll see that the implant, after extraction of this deciduous molar, the implant is basically placed in intact native bone in the central part of this, or in between the alveolus of these roots, the mesial and distal roots. So there's no issue of placing an implant in extraction sockets like this, because we place the implant in native bone. The other thing we need to consider is, of course, the relationship to anatomical structures, which faces this case that I'm showing you the X-ray of now. So there's no apical bone. We know there's a buccal defect. We know there's a chronic infection. We know there's no bone surrounding the alveolus. There's nothing mesial distal we can use to adapt this one, or palatal in the sense that we could use it. So my treatment of choice for this one is conventionally too delayed. So we need to extract the tooth. We need to wait at least 12 weeks for this one to heal. In my clinical experience, I'm placing an implant, I'm doing my necessary GBR, and the implant is restored at the end. So sometimes we cannot go immediate on all the cases. But many of the cases have different types of defects. And as with infections, defects in itself is not a contradiction to immediate treatment protocols. We just need to know how to apply a technique that predictably resolves these defects. And the classification done by Bennick and Hamela back in 2014 is valuable, I think, in the clinic. It goes between 0 and 5, and it goes on different defects. On class 0, there's an intact, basically intact and sufficient bone volume. It's just like a small thing with a soft tissue contour. On class 1, you'll see that we're placing an implant in extraction socket, but the rest of it is intact. Class 2 is a defect in the what we call the peri-implant dehiscence with support from other bone in the area. And then we have class 3, which is a peri-implant dehiscence without support, which is a little bit more challenging. The class 4 is horizontal, needs to be augmented, and class 5 is for vertical augmentation. We look upon how these different defects are treated. It's interesting to see that both class 0, 1, 2, 3, and also many of the cases of class 4 will be treated by resorbable membranes or and particulated bone substitute. It's only for the vertical defects that we really need non-resorbable membranes, even reinforced ones. like this, and also maybe a autogenous bone block. So what we have from the shelf, we can use for many of the indications that we need to augment bone in. So let's put this into a case again. This is a young female that has symptoms from her upper first premolar, tooth number 2-4. When we extract that tooth, we see that there's a defect, but there's apical bone, there's chronic infections, there's potential of having stability of the implant in this case. So you see the buccal defect, you'll see the implant place, you see the particulated bone substitute, you see the resorbable membrane, you see the primary closure of the area, you see the reopening, the abutment surgery, and in this frame you'll see the finalized results 3 years down the road. All cases, but showing again the principles of using even these types of implants in immediate type treatments. So my choice, whenever I'm able to do so, is immediate. But it goes again to whenever the benefits exceeds the risks. So let's go again. We got a premolar. It's a upper left second premolar. It has an infection, there's symptoms. The endodontist has given it up. The restorative prognosis is not good. So we're going to extract this tooth. So the treatment approach choices that we have is we're going to do an immediate treatment, immediate implantation, immediate restoration. Well, we need to consider the same things: infection control, defects, bone surrounding the alveolus, and a relationship to anatomical structures. And in this case, the most limiting factor that we have is the lack of apical bone. And the lack of apical bone, bone apical to the alveolus, is the most challenging factor when we are trying to do immediate implantation in the posterior sites. So again, a case that will be treated classically, extraction, allowing for early placement, allowing for basically what I call conventional loading in 12 to 16 weeks after placement, with these types of implants that I used years ago to treat these cases. Another premolar, we'll put it now on the right side, so it's a upper right premolar, second premolar, tooth number 1-5. How about I go again? So we go again with infection control, we go with defects, we go with bone surrounding the alveolus, and the relationship to anatomical structures. So there's no infection. It's just a tooth that is non-restorable. Bone surrounding, well, it's a narrow root, but still the most important thing is the apical bone. We see that there's a specific distance from the apex of the tooth up to the sinus and the nasal cavity. So we are able to extract the tooth, place an implant. We're also able to do a prosthetic procedure in short time, like 8 weeks after this extraction, or 10 weeks after the extraction, and then we have the finalized tooth in 12 weeks. So we're saving the patient a lot of time, reducing time to tooth and reducing the number of visits in our office. It happens with different teeth. And again, coming to a deciduous tooth on a premolar, I just want you to really understand that if we do the same analysis on a tooth like this, that is basically without roots, we are not operating in an extraction socket. We're operating in healed bone. The roots are nearly resolved completely. So why not, at the time of surgery, at the time that we actually extracted and placed anesthetic, place an implant? A careful, nice surgery for the patient. And after 6 weeks, in this case, because we placed the implant in healed bone, native bone, we are able to place the restoration in 6 weeks' time. Again, reducing time, reducing number of visits. So that's about 3 molars. How about molars? Well, it's the same analysis. We do the same thing. We do what I advise you to do. Infection control, consider the defects, look upon the bone surrounding the alveolus, and also the relationship to anatomical structures. In this case, no specific apical infection. You might say there's a marginal infection or an inflammation, but it's definitely possible to carefully split this tooth or split the roots, carefully remove them, and place an implant in what is basically native bone in between the mesial and distal part of the alveolus. Again, saving time and surgical interventions for the patient. We'll move to another patient. On the other side, same tooth. So lower left first molar. What you see here is that we do the same analysis. We do infection control. We do defect evaluation. We look upon the bone surrounding the alveolus, and we look upon the relationship to anatomical structures. In this case, you see what I call active infections on both roots. And the bone in between the roots seems nearly like dissolved. So this is not a case I like to do as an immediate implant treatment. So sometimes we choose to go back. We choose to do it traditional. And as we are able to do so, we can maintain control of all these different things, of all the different treatments that we are performing. So we extract, we wait for healing, place an implant, wait for healing, and then we do the permanent restoration. So the learning objective for you, from me, when you're planning for immediate installation is infection control, defects, bone surrounding, and the relationship to anatomical structures. Let's put this into a clinical case again. A upper molar, first molar being sectioned and removed. So you see on your upper left picture, you'll see that I have removed the the palatal root. I've removed the mesial buccal, but I left the distal buccal root in situ. Because I need to remove bone to be able to remove them. So I'll leave it for now. I'll start with the pilot drill. You recognize the 2.2 drill. As we move along, you'll see the 2.8, the 3.5, and the 4.2 drill. That is in your middle right picture. After we've done drilling, or after I'm done drilling, it's easy to remove the distal buccal root because we have opened with the osteotomy enough place to remove that root without removing any more bone. What I'm doing is that when I do these upper molars, I'm always basically, if there's not like excessive bone volume up to the inferior part of the sinus, I'm always breaking that bone a little bit up to the sinus so that I'm able to sink the implant specifically into the position that I would like to. But I'm always putting just a resorbable collagen sponge, as you see here, just down in the part of the osteotomy. So I'm kind of pushing this small pillow up towards the sinus, so I'm protecting the membrane on that one. So going on with that one, you'll see that after applying this collagen sponge, the osteotomy is done. Central line, you'll see that I'm inserting the implant, and at the central line of the pictures on your right side, you'll see the implant being inserted and stopped at 50 Newton centimeters, even in an extraction socket like this. That comes to the macro design of these fully tapered implants. After adjusting this one, I'm going a little bit back and forth with this one. I'm able to place the vertical direction that I would like to be, vertical position that I would like to be with this implant. And then I'm closing the gap with biomaterials. I'm using a wide diameter healing abutment to close the soft tissue, and then I suture. And then it's going to look like this. So we're going to have day 0 in the middle, and we're going to have 12 weeks at your right. And when we come to prosthetics, on the posterior side, using a system like the Straumann BLX that has one prosthetic connection, and that we have one scan body, and that we can use the 3Shape scanner to just make this one, and then it's bread and butter time. So it's scanning, it's a monolithic crown, it's screw retained, it's closed with Teflon tape and opaque composite. It's what we do every day, and we need it to be predictable and kind of an easy procedure to perform. So let me tell you a story about a good friend of mine, because she came into my office probably more than 10 years ago, and she looked like this, or basically didn't look like this. She had a bridge. Our endodontist had now did revision of both the endodontic treatment on these abutment teeth, and they look brilliant. And she's happy because there's no symptoms. But it's a story of decision making, because 3 years down the road, the first abutment tooth is lost. It's lost due to an infection, probably caused then again by a vertical root fracture. So at that time, my choice was to remove the root due to the fact that there was infections, there was a close proximity to the sinus, and there was a large defect. So we waited for healing, and then I inserted 2 implants, and we restored them. And she's happy, at least for 1 year, because a year after, abutment tooth is lost. At that time, I'm trying to save her from a lot of appointment. So I'm saying, hey, let's do this immediate. I'm considering all the things that I should consider when performing this. But I see when I'm performing the procedure, hey, the defects are bigger than I thought. So I end up using the palatal part of the alveolus as my anchorage for my implant. And the healing works well. So I'm placing the implant, it's restored. The only trouble is that the prosthetic connection of this implant is placed very on the palatal surface, or palatal part, as long as it's placed in the palatal extraction socket. Might not be a challenge, but it is. It looks fairly good on the x-ray, but if you look on the clinical part, you'll see you need to build the crown a lot with an emergence profile that's not healthy towards the buccal part of the occlusal table. So she comes back basically later the same year, and she's lost something. She calls me, she's lost something. Comes back, and what I see on the x-ray, I see the rest of the implant, and she's bringing this part with herself. So there's a fracture of the implant down in the extraction socket. I'm waiting for normal healing, re-entering, I'm placing another implant, I'm waiting for conventional healing, and then I restore it, and she's happy again. The learning from this one is, do not choose the palatal alveolus in the upper jaw when you place an implant. Immediate restorations is another topic. It's not that big on the posterior restorations, but you need to check the same things, even though it's anterior or posterior. So it's a T position. Is it a posterior molar? Might not be that important to the patient to restore that one immediate. Are you able to obtain primary stability of the implants? Do you have occlusal control so that you can avoid any kind of loading on the implant? How about logistics? Is it planned in time, in components, in everything you need to do these restorations? And does the patient really understand how complex this procedure is? Are they able to perceive and go do what you tell them to do? Namely, do not chew on that tooth for a period, because either you'll destroy the integration process or you'll destroy the temporary restoration, because it's basically built on plastic. My 2 biggest issues very often is logistics and the patient issues. On cases like this, we're missing a left lower premolar, and there's a healed bone set, and the patient is very concerned of having a tooth as soon as possible. Of course, we can use the same thing, the temp shell technique that it's shown in different lectures, and there's a webinar with me showing it on the aesthetic area, and it's easily adapted on temporary abutments. They're cut down, shaped again with composites. It's done chair side, it's screw retained, and it looks good. So it's possible to do. So if we combine these types of treatment approaches, and we look upon the case that we started with, the failing tooth 1-6. What more information do we need? Well, I would recommend you, in as many cases as possible, when you are doing immediate treatments, when we're doing immediate installations, get yourself a cone beam CT of the area. What it shows in this specific case is that you have a highway of native bone in between the roots and also apically from the roots before you hit the sinus inferior floor. So why not carefully split these roots and install an implant? And also at this specific case where the patient was very concerned about not having a tooth in the area due to smiling issues, also place a temporary crown out of occlusion, as we call the immediate restoration. You see the different steps, and if I'm able to, I'll highlight some of them. You'll see that we are splitting or separating the roots. You'll see on your far right, you'll see the last alignment pin on 4.2, so the final jaw is 4.2. You'll see me removing the palatal root after the final osteotomy, because then it's easily removed. You'll see me installing a 5.5 implant. You'll see the torque being checked to 35 Newton centimeters. You'll see me adapting biomaterials in the area. And you also see the temporization with the temp shell technique. And this is what you find when you have the patient in your first control, after extraction of a tooth, after installation of an implant, and after a temporization of this implant immediate. I'm getting close to the end, but I'll show another good friend of me who came to my office with this failing upper left premolar. And he came in, it was 1 or 2 days before he was leaving to Las Vegas last year. He was out to some fun adventure, and this tooth was failing, it was in pain and was loose. I'll try to show you the small videos that shows on your left side the pre-op situation, where you'll see I'm trying to move this, I'm trying to film and move it at once, but you'll see it's quite loose, so there's a lack of retention of this tooth. And on the right side, you'll see the temporary crown that we placed on top of an immediately installed implant in this area, obtaining the correct primary stability needed to do these types of treatment. And you'll see that there's no loading at all, no occlusal contacts on the tooth. So 60 minutes is what we need to do these procedures. And on your lower right side, you'll see the finalized crown on this tooth being placed 4 months later. So trying to give you a decision tree on when to do what. Infection is one of them. Is it a yes or no? Is it chronic or is it acute? If it's acute infection, do not go for immediate procedures. My recommendation to you. Is it chronic or no infection? Can you do an extraction carefully, like straightforward, or a little bit advanced, like splitting some? Is it complex so much that you need to remove a lot of bone to have to remove the roots? Don't go for immediate treatments. Is there apical bone? Because apical bone is basically the key in many of the posterior sites. Is it a yes? Go on. Is it a no? Wait with the immediate procedures. And the last thing to consider, is the patient aware that you're doing a complex procedure? Are they able to avoid chewing on the tooth, take care of it in the same way? If they are, it's even a candidate for an immediate restoration. If not, it might be a candidate for immediate placement, but definitely not for immediate restoration. Summing up, what I've been trying to show you now for the last 50 minutes is that we're talking about refinements in implant dentistry. Immediacy is nothing new. We're just trying to refine the procedures. Always work with protocols that provides you with more benefits than risks. Be very proper with your case selection. Learn slowly. Do your learning curve on this one. expect some complications, and learn and discuss and evaluate and develop on them. And develop both knowledge and clinical skills. So I hope you enjoyed our time together. I for sure did. And if you have any questions, please feel free to add them afterwards now. And also, if there's anything, you can contact me on my social media profiles on Instagram or Facebook. If you would like anything to discuss, I'm more than happy to connect with you. And by that, I wish you a very nice evening. Please stay tuned because Dr. Polito and Dr. Teppa will come on with great lectures. There's going to be a lot of learning, and I trust that you are happy spending your time with us. So thank you for your attention, and I wish you all the best, and feel free to post questions if you want to do anything on the Q&A session. Thank you. Yes, so hello everybody, and thanks for your kind attention wherever you are in the world. We have got a few questions, so I will try now to use about 10 minutes to answer as many as possible of these, and then we'll see if there comes up any more discussion on this. Thank you for your kind questions. These are excellent. So the first question comes from Dr. Abarca, Jose Manuel Abarca. And he's asking about the future compatibility with CEREC solutions for BLX. According to my sources, this will be available from this summer and on. So the next update will include the accessibility of using the CEREC system with the BLX. There's also one from Dr. Huang, which is a question on immediate placement. How deep do you go subcrustally? As this lecture is about posterior sites, I'll answer about the posterior sites. I traditionally always sink my implant at least 1 millimeter below the lowest part of the crest. So if we have a buccal crest that is a little bit lower than the palatal one, it will be even more deep according to the palatal wall than the buccal wall if it's lower. So at least 1 millimeter I would recommend in immediate placements. There is a question from Dr. Squell on using PRF instead of resorbable membranes. I've read the studies and most of these things, and it's showing good results now with the PRF and the different membranes. So it's interesting. Personally, I'm still using the off-the-shelf products of resorbable membrane because it's working fairly well and predictable, and it's not very time-consuming producing it or any more hassle with that one. So, but I think it's a fair alternative. And then we have from Dr. Murthy, how long do we need to wait for loading after immediate placement of implant? It depends on where you place the implant. Because if you place the implant in like most of native bone, like you do in some cases, because there's plenty of bone in between these extraction sockets, you could basically wait as with normal healing. And with the SLActive system, for me, that's 4 to 6 weeks. If you place it in an extraction socket that you don't have that much of native bone, that much of intact bone, I would recommend you to wait 3 months, 12 weeks. And then there's a question, it's the same, it's from Murthy, Dr. Murthy again, thank you. How should the torque be in immediate placements? There is no rule for immediate placement torque in itself, because like immediate placement is primary stability. If you're going to load the implant, if you're going to restore it in some way without loading or something, I would recommend you to use at least 35 Newton centimeters. But in itself, it's primary stability you need. And primary stability is, I'm not very comfortable leaving an implant if it's not getting me 15 to 20 Newton centimeters. On early placement, is it really need to curettage the fibrous tissue on extraction socket before osteotomy at second? That's from Dr. Andre. I do. I'm not sure if it's necessary, but I do, because in some it depends on who extracted the tooth, because you have different routines when you extract the tooth. Some of the part in the extraction socket at the second surgery will be bone in healing. So you might remove some of that, but I would not like any granulation tissue, anything in the area when I place in the implant. From Dr. Murthy again, is it advisable to immediate placement of implant when the bone type is D3? Yes, I cannot see any contrast. You need to use these specific implant systems. A fully tapered implant system means that you use an adaptive drill protocol. And I think that's the key for everything that we work with in these types of extraction sockets, is being adaptive. And then there's from Dr. Jagati, which is the loading protocol. When you say delayed loading for the upper and lower posterior, when I'm using the SL Active, I'm traditionally in healed sites, I'm using 4 to 6 weeks. So when I wait 12 weeks, I call that basically delayed loading in our clinical practice. And then comes a couple of questions from Dr. Farshid and also Dr. Katheng, asking about these roots that I left in with the implants. And I think if you go back, look at this now, you'll see that I left the roots in as I did the osteotomy. Due to the fact that if I was to remove these roots before I did the osteotomy, it would be necessary for me to remove bone, to have these atraumatically removed. So instead of spending a lot of time on that one, I'm doing my final osteotomy to see that, hey, I removed enough bone now to remove these roots without any kind of damage more to the bone in the area. So that's why I'm leaving these roots. And then that was the roots and the roots. And then there's interesting questions about the implant that fractured. You saw that this implant was another system, a fully tapered implant system that I've been using since 2007, and which I changed into BLX system now 3 years ago. But it broke, and the apical part of the implant is integrated. There's no infection on that one. So what I did in that extraction socket, I left it. I left it because it's integrated. There's no use of doing a big surgery in that one. And it was not positioned in the sinus. It was positioned in the palatal part, the palatal alveolus. So it was left up there. So not removing that one, because that would be a big surgery without, what's the benefit, in my opinion. What kind of implant are you using? Doesn't look like ITI. Well, there's no system that is from Dr. Navazam. Well, the ITI is an organization and Straumann is the implant. So Straumann tissue level, bone level and things. The implant that I'm using today is the Straumann BLX, the fully tapered implant. In some of the cases you saw the fully tapered implant from another producer called Novel Active. Let me see again. Yeah, these roots that I left, I didn't leave them. I just left them when I did the osteotomy, so I removed them before that one. Is it possible to get the flow diagram for the case selection? Of course, this is from Dr. Wakim. Please just contact me on Facebook or Instagram, and I will send everything, whatever you would need. Thank you for all your kind comments. You spoke about chemically disinfecting chronic infection socket. What is your technique and material from this? From Dr. McLafferty. I'm using chlorhexidine. So I'm mechanically debriding, and then I'm rinsing with chlorhexidine in the socket for 1 minute. So that's what I'm using. That's the technique. It's 0.12, as we use in Norway, 0.2% of this one. And then there's a lot of questions. Thank you so much from Dr. Agafli, that stating lower immediate loading is more predictable than upper. Would you always agree? Meh. Immediate loading is, in our opinion, is what we do when we do full arches. And I cannot see any difference in our practice between immediate loading on full arches in the upper jaw versus the lower jaw. It seems to work well. It's depending, again, on all these case selection criteria that we talked about. What material do you, sorry for this one, we see again from Dr. Centeno, what is your protocol antibiotic for a teeth with apical pathology? Well, basically, if it's chronic infection, I'm cleaning it out mechanically, I'm putting in the chlorhexidine, and I don't use any antibiotics. Besides the 2 grams of amoxicillin that I'm always using preoperatively in all the implant cases. I see that my time is probably running away, and there's some more questions. Let me finish with one of them. Can I do that? One more question I'm allowed. I will do the last one, which is good. It's from Dr. Vella from Malta. Thank you. It's nice. It's many years since I've been there now. What do you do if an immediate implant fails? I admit it. That's the first thing. Just admit when something fails, remove it, wait, and do another implant. Implants fail if they're immediate, if they're conventional, early. It happens. It's just a matter of time. So admit when something fails and redo it and make the patient happy about it. Thank you again for everything. It's been very nice to spend some time with you now, and I trust that you're all safe and healthy all over the globe. I hope to see you soon. Contact me on every media that you would like, and take care and stay safe. Thank you.